Thank you, Professor Dogra, for the opportunity and to be part of this IC. My task is to talk about the managing the RD secondary to the necrotizing retinitis. So we see these necrotizing retinitis in the patient of viral retinitis, be it because of the HSV, VZV, or CMV retinitis. That's a common CMV we see in case of HIV patients, and we being in a tertiary center will see a lot of these patients. So there is a lot of destruction in the retina there, and retina becomes weak, and there is something going on in the vitreous also. So whenever these changes are there in the retina, so retina heals with some kind of atrophy there. So that edge of a normal retina and the atrophic retina, it becomes a weak area, to which this vitreous can play a spoil sport, and it can cause a detachment there in the future. The detachment rate is so high that it's more than 50% in ARN patients, and nearly 30% case of the CMV. And we must know that, as I've already told you, there is a peripheral retinitis going on in these patients, and when the problem starts actually. So see, in this patient, when the same patient, when the healing has started taking place, there is an atrophic area behind, and this atrophic area and the margin between this retina and here the breaks can form, and it will ultimately lead to the detachment in these patients. And if you can pick this detachment and treat them, these patients early, and somehow they do well, because in them also the PVR can set in very early. And ARN patients, because they are normally not immunocompromised, so these patients can be taken up with surgery early. But CMV patients, you have to talk to the family and talk to the physician and then take up for surgeries. And when you before I move on to the RD in these patients, is there any role of a prophylactic the laser before PPV in these patients? And of course, people have addressed the prophylaxis, that doing a barrage around these necrotic areas and trying to prevent RD, which is ultimately they said it's going to happen in these patients. But there are no head-to-head trials, and some studies show good results, some study don't show good results. So there the things are not very simple, as simple as like in coloboma. So we really don't know whether it does have a role in case of retinitis. In our hands, it has never worked. Wherever I tried the doing laser, they have detached. So probably I think by doing a laser there, I'm causing another a weak area to which the vitreous is manipulating and trying to produce. It acts as a break there. So it doesn't work in my hand. When I move on to the how to operate, what are the special things which are needed in these patients apart from the usual RD vitrectomy? So whether to do a PPV or a buccal alone is cases with the mild vitritis where you have a localized quadrantic superior or inferior RD, which are hardly we see these patients, one or two patients after a long time. Majority would need PPV, and because they have large and they are kind of they're mostly the post-equatorial, the posterior breaks are there in these patients. So what all is required in the vitrectomy there? You need thorough debulking there. And what is important here is when are you trying to remove the hyaloid in these patients, there is a formation of vitreous schisis there. One thing is most important is whenever you try to go for the overkill, you tries to detach retina over the hyaloid over the atrophic areas, you tend to cause more damage. So best is just to at the edge of the atrophic and the normal retina, if your hyaloid is not coming easily, you shave it off completely and leave it there. Don't go overboard, because you may cause more harm. You will be creating large big tears which you will not be able to manage in these patients. And role of lensectomy, because most of the patients you will require oil in these patients. So lensectomy for peripheral dissection, whether to do or not, you have to actually take a call. If you have a previous lens opacity is there, people have did phaco and oil there, IOL in these patients, and then went out to do vitrectomy. But since the breaks are not peripheral, they are posterior, so lensectomy is most of the time is not required in these patients. But later on, the phaco IOL will give a good rehabilitation to these patients. Again, to buccal, theoretically, people said that you put buccal in these patients, but since the PPV is doing taking care of the vitreous, the buckles are not required in all the patients, because as I've already said, these are posterior breaks. The whole of the peripheral retina is atrophic. The oil will take care of that. But in case you have an inferior RD with an inferior break, which we know that which will be well supported with the buckle there, and you can of course go and do a buckle along with the PPV in these patients. But for inferior atrophic areas which are far posterior, you don't need buckle for these patients. Of course, fluid air exchange is also little whether to there will be pre-existing areas through which this can be done. But the issue is you can't laser these atrophic areas. This is difficult. So people talk about doing retinotomy in these patients, especially where the RD is there in the active disease actually. So you can do retinotomy, or you can drain through the pre-existing area in these patients. So how much laser? Laser does have a very good, it has to be done extensively. Apart from the posterior barrage, you have to really go for the anterior edges, because sometimes these anterior retina is a normal retina. It is not that atrophic. You have to go beyond the beyond the equator to look for these edges and do a laser there in these patients. There is no role of laser in the atrophic areas. The marks they don't come. So you have to do a barrage kind of a laser along the posterior and the anterior retina. And pan-retinal photocoagulation, sometimes it is required in the patients where they are their CD4 has gone up and they are showing the vasculitis and the vitreous hemorrhage, and you need to do a pan-retinal photocoagulation in few of these patients. Oil versus gas. The gas was used initially, especially in case of ARN patient where you had superior RDs with superior tears. You can use gas in these patients. But of course, when you have atrophic areas, inferiorly large atrophic sieve-like retina, the gas will not work there. So you put oil in these patients for the increased success, and there will be a reduced need for buckle also. So the oil is the end thing. The gas will be only for the superior RDs where you are not seeing a lot of these sieve-like retina there. Which oil? Again, people are fond of using 5,000 or 1,000. Which one to do? My take is, I use for one-eyed patients. I know that these are the CMV, HIV patients, and they are surviving, and so I'll be putting 5,000 in a one-eyed patient. And of course, oil acts as a kind of an agent which will take care of the antiviral kind of activity. So active disease, you put 5,000 IOLs. This is there, and you can use 1,000 or your 1,200 cc Santi-Stokes oil in those patients. So what are the attachment rates there? Using the complete maneuvers, I've already explained. The reattachment rate is good. Nearly 90% can be attached, but despite the attachment, we have because with the attachment the game is not over. You have to have patient of re-RD. You will have your hypotony in these patients, and you have subsequently the immune recovery uveitis like problems in these patients. The visual prognosis, of course, you are operating these eyes which have vasculitis, which have retinitis, and which have vitritis, and you know that their optic disc is most of the time is compromised. So you should know that despite of your good job, your visual recovery will depend on the state of the optic nerve, and it will depend on the area of the retinitis. If the area is too far posterior part is involved, so you may not have good visual recovery. And of course, pre-op visual acuity does have a role here. Better the vision, the better the outcome in these patients. This is one of these patient where the surgery was done. Most of the time, you don't see the active disease along with the RD, but in this patient, there was an active disease going on in this patient, and you see I left the hyaloid in that area in this patient. I didn't go overboard, especially over the active disease, because if I try to trim it too much or try to pull it like a normal PVR membranes, I may cause more damage in these patients. So shaving is the best technique in these patients. I did retinotomy in these patients, and then the barrage lasers, it is like usual 2 to 3 rows of lasers are given in these patients before giving a tamponade in these patients. This is another patient where the atrophic sieve-like retina was there, and of course there was involvement of the fovea there. You can see the Schleiden effect there, the large atrophic break there from which the fluid is coming. So again, after the thorough debulking, and you also see PVR in these patients because sometimes the RDs are old and they do get PVR changes, so you have to leave the membranes, and just like a normal vitrectomy maneuvers, we do all the maneuvers. In this patient also the PVR was removed and the fluid gas exchange was done, and it was drained through that large atrophic hole which was already there. I would end my talk with the carry home tips here in this patient, because you must remember that no longer in HIV patients, no longer these are palliative surgeries, because these patients are now surviving for long. So onus is on us that because they are surviving but they can't see. So you have to go for a definite treatment in these patients. You have to put oil in these eyes. You have to later on do cataract surgery also in the eye. You have to sometimes remove also oil in these patients. So good meticulous PPV, SOT, and scleral buckle plus minus is the key to success in this patient. But attachment is not the end of the journey. You have to, because these patients are surviving, and you have to do multiple surgeries in these patients to keep them seeing. Thank you so much for your patient hearing.